Okay. Good afternoon, everyone. My name is Drew Engles, and I am very happy to be here. I'd like to thank a couple of people first. Michelle, who is running the whole conference and then invited us. Ted, who helped me get my um, talk actually into cyberspace because I'm not very good at that. Just ask my kids. Um, and I'd especially like to thank my partner, Dr. Stephanie Russo, who joined our practice 2 years ago. And Jerry Barnett, who's our nurse practitioner, who helps us in the office and in the OR. I learned very quickly after she joined us that people come to see her in the office and they tolerate me. So that's kind of how things. Um, Now we're from Akron Children's Hospital, which is about an hour and 50 minutes away from here. I understand there's a lot of folks from around the country, so welcome to Ohio. Um, I am actually not a native, but we're glad you're here. Um, and most of the time when I do these talks, I start off with things rather scientific and then get to things more philosophical. But I'm going to start a little bit more philosophical today. Obviously, I don't need to repeat all these numbers and stuff like that because you guys are so aware of this and understand it. Um, you know, I've seen the 1 in 3,000 website, different literature scattered today. So I'm not going to talk too much about that. Uh, Often the kids that come to our office see our partners first because on ultrasound, sometimes up to like 63% kids who have tuberculosis present club feet in their ultrasound and hand issues. Um, say philosophical is that you guys who have children with tuberculosis are often the first resource for people who are newly diagnosed and prenatal diagnosis, and uh, it's it's so important, or we like it so much when people come to see us even before they have their children. Um, Most of our referrals come from maternal fetal medicine programs, and they come by via ultrasound things. And what you'll see in the pregnancies is typically limited fetal movement, malposition of the limbs. And what I mean is typically the legs will be straight out, and they'll often be crossed at the feet, which is not a typical posture. And often the arms will either be fully extended or with the hands in flexion or the elbows fully flexed. And usually you'll see that there's contraction or limited motion at least two or more joints. There can be some narrowing of the chest cavity. There can be some insetting of the joint. And nuchal edema is the fat pad behind the neck, which will be different width than you'll typically see. Um, Now, pregnancy is a daunting experience for all parents, especially first-time parents. And this anxiety can be heightened when there are concerning findings in ultrasound diagnostic testing. And so I think when you get to meet a specialist prenatally, you can answer a lot of those questions that pop up. Knowing that there's a team supporting your family, there's a game plan in place, it can be very reassuring for these parents. They come in bewildered and they kind of leave with this sense of, I think something can be done. I think we can be helped. It's also important that they understand right from the onset that um, hand therapists and occupational therapists and physical therapists are in life, and that participation by the parents fosters a sense of shared purpose between us and the family. And it's important for them to know that they're not in this alone. So, a lot of what we see as hand surgeons is distal arthrogryposis. So, we'll share patients with partners who take care of club feet, hip dysplasia, and so forth. And there's about 20 more subtypes, and every year there's new genetic markers that are being found and so forth. But even though we're surgeons by training, the vast majority of patients that I take care of, I typically have more to do with their bracing and interacting with our certified hand therapists, making sure that we optimize their splints and their non-operative care. Um, and, 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 and again, the majority of them probably don't have surgery. And for the ones that do have surgery, I have been taking care of 3 to 5 years of their surgery. Um, and then a lot of it is figuring out what little tricks that kids develop and trying to make those as optimized as possible. And therapists are just phenomenal about doing it because every kid is different and every kid has different needs. And they can make a whole bunch of difference through splinting. This is just an example of one say system, and this is kind of like the pediatric version. And for some people, it works extremely well. Some people will try and then kind of give up on it. It's just things that it's not it's available. Excuse me. Now I'm going to talk a little bit about um, the lower portion of the overhead as far as what things we can do for patients. And we can't do this for everyone, and it's not the right answer for everyone. But this is just to give you kind of an overview of some of the things we do as pediatric hand surgeons. So we'll start with the wrist. And what we do with the wrist in some instances is actually what's called a dorsal carpal wedge osteotomy. And what we do when we're doing is we'll take the center of the wrist and we'll actually cut a triangular piece out and then close that as if you're closing the book back open. So it's like essentially opening a book, taking out the middle third of it, and then closing it back together. Now what that does, if you can look at this diagrammatic manifestation of it, is that we'll take bone from the I will never be a Jedi Knight. So, so on the upper right, you'll see that we take a wedge from the top, and then that closes it. So you take a wrist that's sitting in flexion, and by removing your triangle, we're going to bring it up into extension. Also, there's typically some deviation of the wrist, and what we'll do is we'll bring that into a more neutral alignment. And what's important about this is it sets the wrist in a better posture, but not only does it set in a better posture, it actually makes your fingers function better. And what I mean by that is if everybody can just take their own wrist and bend it down as far as it goes and try to make a tight fist, okay? It's not that easy, okay? Bend yours back and make a much tighter fist. So by setting the wrist in a position, we can actually improve finger function and grasp. Uh, yes, sir. It's typically only done on pediatric patients because and you can actually cut through the bone there with a scalpel because it's most of the wrist is cartilage at that point. And some people do a little different. Dr. Russo will just suture the bone back together. I'll suture it and put some pins in, but you can get away sometimes with just actually suturing that cartilage together. So it's typically done more for the pediatric patient. Now, Dr. Ann Van Heest, who's from Minneapolis, she did a really good study looking at children with arthrogryposis that they did the carpal wedge osteotomy. And what she said was the excessively flexed wrist in children with arthrogryposis can safely and effectively be improved with dorsal carpal wedge osteotomy, which in turn facilitates independence in activities of daily living and school-related tasks as reported by their parents. Now, the other thing she found was that typically worked better on kids that were 7 or older, and it typically worked better in kids that also had their extensor carpi ulnaris tendon transferred at the same time. So what we'll typically do in combination with this is take that extensor tendon that sometimes turns the wrist this way and reattach it to one of the more central wrist tendons so that the pull is midline rather than deviating. Again, trying to get that wrist in a more neutral posture. And then our post-op protocol for that is typically I'll put the kid in a cast for 4 weeks. And since I typically use pins because I'm kind of a belt and suspenders kind of guy, I'll remove the pins at 4 weeks, and then I'll have our occupational therapist fabricate them a splint. They'll wear full time for 2 weeks, and then we typically splint them at night for 6 weeks while they're trying to regain their motion. Now, when we do this surgery, it does not improve their total arm range of motion. It just resets where it starts and where it's finished. So you don't go from having minus 40 to plus 30 that we would get minus 10 to plus 30 or something like that. So it doesn't expand their range of motion. It just makes it more functional. Yes. Now another thing we'll do for thumbs, because a fair amount of kids who have distal arthrogryposis will have what's called a congenitally clasped thumb. So the thumb, and you'll see in this picture on the left, is that it's flexed at the MP joint. The web space tends to be tightened. And what we'll want to do is bring that thumb out and open up the web space. And you can see how limited it is in the right-hand picture here. Oh, sorry. It's telling me the picture cannot be displayed. That's unfortunate. Yeah, I'm sorry about that. Well, if it had been working, what we actually do is we drive the radial index and we lift it, and then we make an incision between the thumb. At the same time, we make an incision straight on top of the thumb joint here. And what we'll do is shave off the bit of the end of the metacarpal and a little bit of the base of the proximal phalanx. Now, we don't get into the growth plate because we don't want to arrest growth. We want to make sure that the thumb continues to grow. But what we want to do is stabilize it from this flex posture to a more functional hinge position. So essentially what you do is you fuse those two bony elements together so that the thumb bend there, it'll still bend there, and it'll still have all of its CMC joint motion, which is probably the most important motion for the thumb. But put it in space so that now we can pinch against it, and it's much more functional than where it sits here. Now, by taking that skin from here, we can grab the body, because we'll always notice that not only is the web space tight, but the upper surface of the thumb is typically deficient of skin, and so we can borrow from Peter a big hole here. And this you can actually close, so you don't need to do any type of skin grafting. We can close this as a straight incision, and then just remove this. And it's a very effective way to open up the web space and make a stable thumb. An unstable thumb is not helpful to pinch or grasp. And it's a very nice surgery. Correct. In an adult, you would do like an arthrodesis for a thumb that was tucked under because you're not worried about the growth plate at that point. But different skin flaps can be done on adults too. So it's called a chondrodesis. Yes. Yep. And then the stiletto flap, kind of like well, if you're a gangster, it's the knife. If you're an expensive shopper, it's heels. But well, sorry about those pictures. And then our post-op protocol for that is a cast for 4 weeks. And then typically we'll put at least 1 or 2 pins in the thumb And then once the pins are out, we'll move that over to a waterproof cast, makes life so much easier. Rubber splint, and do that for 2 weeks. And at 6 weeks, we'll start moving on range of motion. Um, and this is just a reference from the Journal of Hand Surgery where they describe the flap to do this. Theirs has a little bit of difference. They use a back into the web space, but essentially it does the same thing as far as resurfacing the web space. So now for camptodactyly, which is another thing that we routinely see in patients with distal arthrogryposis, there'll be flexion deformities of the fingers, and there's appears to be some webbing of the skin, and we use that webbing to our advantage. So what you can see drawn out here in these pictures is the flap that we take from the side of the finger and then use it to bring, we rotate it around underneath the finger and and then resurface the finger so we can stretch it out. And then this is a picture of before we do it. In this individual, we did all 4 digits. Sometimes we'll only do 1 digit, and then the picture on the right will show you what it looks like when it's sewn in place. Yes, ma'am. No, no, it doesn't impair flexion at all. Now, what we do in combination with this is you'll draw out your flap, we'll lift it up so that it's essentially a free piece of skin just tethered at the base, and then we'll go in there and we'll open up the sheath that the tendons run through, and then there's two tendons to every finger. One bends the end joint and one bends the middle joint. And we'll take the one that bends the middle joint, which is felt to be overactive in patients with this condition, and we'll cut it and release it. So it'll essentially just kind of drift back towards the palm. And but the one that bends the end joint is still there, so they still have the power, and it's actually the stronger of the two tendons for grip strength, but they no longer have that overpull that's making their finger want to rest like this. So setting the wrist in extension is one of the things for the prior procedure that we talked about. No, because there's no muscles in the fingers, it's just the tendon there. So anything that we'd want to do to generate force would have to be done higher up in the biomechanical chain. Um, and then the third thing we'll do is if the joint is stiff, we'll do a contracture release. Now, in some kids, you can just gently, they're pliable enough, and if they're young enough, you can actually just stretch it out. You feel a little click or pop, and you're like, oh, that's much better than before. Sometimes if they're a bit older, you'll have to actually recess the ligaments where you take the scalpel on the surface of the ligament. And so you're not cutting it in half, you're just like sliding it forward, and that will release the joint. So now you have a more supple joint. You have you've alleviated the deforming forces, and then now you have more skin so you can straighten. And, and sometimes we'll do it on all the digits, sometimes 1 digit at a time. Yes, ma'am. Age limit for pediatrics? Well, it depends on the institution. We typically see patients up to 21 on average, but we'll see some patients that are older. We actually have an adult congenital cardiac clinic because it's hard to get adult cardiologists to take care of kids who have congenital heart defects. Some physicians will see kids up to that age. Our maternal fetal medicine clinic sees, obviously any pregnant women, and some of them at higher risk are actually older female patients. Yeah, you can. You probably wouldn't be able to do the soft joint release, um, but it depends. Every patient's individual, so I wouldn't give an age that I would do it at. I mean, you'd want to see what the X-rays look like. If they had, changes on their X-rays, they might not be a great patient for that because you may make their finger move more. But if they have like arthritic change, you may you might make their pain worse. So it kind of depends. You it's not a cookbook in any way. It's like what's the best thing for this patient, and usually it's something that we look at the X-rays together and it becomes a shared decision, not just like what I think you should get and so forth. And it's what they want too. And it's just for anybody who's in Missouri, there's Chuck Goldfarb and Lindsay Wall are fabulous hand surgeons at WashU in St. Louis, and they're the ones who wrote about this in the Journal of Hand Surgery and kind of put this all together. Um, and then our post-op protocol, typically keep the patient in the splint for 2 weeks, and then when they come in for that visit, we'll have them uh, get a custom splint made. And we don't try to get it all the way straight because sometimes these blood vessels have been kind of kinked for a while. And if you try to do that all in one visit, it can end up having an issue with ischemia or impaired blood supply. So we kind of just gradually stretch that out over time. But you can do a lot more now. They have more skin on the bottom, and then they'll do their exercises, wear a splint essentially the rest of the time for 4 weeks, and 6 weeks we just haven't heard it. So just thought about this is that what we're doing here is after all just really bad for our kids, your kids, my kids are a little older now, but that's what we're thinking about doing. So thanks.
Okay. I'm Stephanie Russo. I work with Dr. Engles, who you just heard from at Akron Children's, and Jerry, our nurse practitioner, who's with sitting next to him up there. And so I'd just like to take a moment to say thank you for the opportunity to speak here. I love taking care of patients with arthrogryposis, and I'm excited to have the opportunity to speak with all of you today. I don't have any conflicts of interest to this, but I do have several acknowledgments to make. The first is to a couple of my mentors, Dr. Kozin and Dr. Zlotalo, who taught me much of what I know about taking care of patients with arthrogryposis and who provided a couple of the images in this talk as well. And to my partner, Dr. Engles, who I'm lucky to be able to work hand in hand with to take care of patients together. And you can see in this picture my hands on the right and Dr. Engel's hands on the left. So it's fun having someone to operate with on big cases or when we're doing cases on both arms at the same time. And Jerry was in there too, but her hands didn't make it into the picture, unfortunately. But, yeah.
Is this better? So we're gonna hold it like an ice cream cone, right? Yeah.
Okay. All right. Is that better? Okay. Thanks. And lastly, I would be remiss if I didn't thank my patients and their families that allow me to become a part of their lives and their story and take care of their children. And especially thank you to all the patients and families that provided their consent for me to use them in this talk today. And so, as we all know, arthrogryposis presents in many different ways. There's all different sort of shapes and sizes and functions and needs and wants. And I think that's one of the things that's most fun about taking care of patients that have arthrogryposis is figuring out that individualized plan for each patient, what they need, what they want, and the best kind of unique combination of things to optimize function. And so, not everyone's the same. There's all different kinds of arms and hands, and we can make them work to the best of each individual patient's ability. And I think it's also important to remember that arthrogryposis doesn't just affect the person who has it, it affects people around them as well, their families and friends, and their social aspects, and all of those things have to come together and be considered when we're making decisions about care. And so I think there's a lot of other components with that to keep in mind as well. So in this talk today, I'm going to focus on the upper part of the arm, the shoulder, elbow, forearm, as Dr. Engels already talked about the wrist and hand. But what you'll see is that really it all comes back to the hand. And you'll see that repetitive theme throughout this talk today, that even though we're talking about the shoulder or the elbow, really the goal is related to the hand and the importance of optimizing hand function and position. So the most common presentation that we see related to the shoulder or the humerus, the bone in your upper arm, in people who have arthrogryposis is that internal rotation contracture, where your arm is tilted or is rotated internally quite a bit. And it can be fairly substantial in people who have arthrogryposis to the point where your hands may face away from each other and you require that kind of scissoring pattern to grasp objects. And you can imagine if you don't have arthrogryposis, if you put your arm in that position, you can't even see the palm of your hand very well. And so it becomes very difficult to develop your fine motor skills when you can't see your hand. And so one of the things that we can do to help this for a lot of patients is what's called an external rotation humeral osteotomy. And what that entails is that we take the humerus, the bone in your upper arm, and we actually cut it and rotate it into a more functional position, and then use typically a couple of plates to hold it back in place while it's healing. And people actually tolerate this very well. It's because of the plates holding it in place, it's not a very painful procedure, and it can be really helpful to get the arm oriented in a better position for function. And so you can see this child here who has had surgery on his right arm, but not yet on the left side, and you can see a big difference in the position of the hand between those two images. And I think you can imagine once he had the other side done, and those hands are facing each other now, how much more he'll be able to use them. What you can do with your hands when you can actually see what you're doing goes a long way. And then as we move down towards the elbow, some of the more common presentations of the elbow are stiffness and weakness of your elbow range of motion. You can see it in both directions, but probably most frequently we see arms that are stiff in extension, meaning the elbow is straight and it's difficult to bend the elbow up. And there's a procedure that we can do for that. That's an elbow release. And that involves lengthening the muscle, your triceps muscle that straightens out your elbow on the back. So this kind of diamond shape or V-shaped incision there is lengthening the triceps tendon. And then in that center picture, we're actually releasing the elbow joint itself, the tight aspects of the joint in the back, to allow the elbow to bend more. And then we reattach the tendon in a more lengthened position, so that that provides a greater arc of range of motion for the elbow. And this is not just about the surgery. Therapy is important for most, if not all, of the procedures that we do, but this one in particular requires a very intensive therapy afterwards to try and maintain that range of motion. And so working together with our therapists and the families to achieve the home exercise program and the outpatient therapy is really important to have the best possible outcome after this procedure, and it's a big part of the success of the procedure. And so what you can see afterwards is having that increased elbow range of motion. And the benefit of that is being able to position your hand in more positions. So one of the big goals is being able to feed yourself, getting your hand to reach up to your face. And so even to just achieving passive range of motion can help you do that by having a table that you lean onto or using your other arm to help and things along those lines. The elbow release by itself does not necessarily give you active elbow range of motion, meaning that you yourself can bend it up. If you have those muscles present and they're working, then you may be able to use them after the elbow release. But if those muscles aren't working well enough, it just gives you the passive motion, not the active. And unfortunately, we're not a magician. I can't pull something out of nothing or a rabbit out of a hat or make your elbow bend if you don't have it. But sometimes we can take another muscle that's in the area and transform it into an elbow flexor to provide that function in kids that have an extra muscle that we can use. The best one and my favorite to use is your latissimus, which is big, broad muscle in the back of your chest. It's a muscle that turns your shoulder in and brings your arm down, and so there's not typically any functional loss from taking it to turn it into an elbow flexor. It's a fairly big procedure in which we dissect that entire latissimus muscle up off of the back, and then we leave it attached to its nerve and blood supply, but completely detach the muscle. And so here you can see that initial big, broad latissimus muscle that's been rolled up into sort of the shape of a biceps muscle, and when we're stimulating the nerve there, that muscle is contracting. And then we take that muscle while it's still attached to the nerve and blood vessel, so it's still alive. Down at the end, and we attach the muscle at through the slide in the operating room, how far back I can get her wrist and fingers. And so this is taking into account all those same considerations that Dr. Engles talked about already when we're looking at people for a carpal wedge, whether they're a good candidate or not. One of the considerations is your ability to open your fingers. And so this is Joe, who you may have seen here around the conference, but we're going to kind of talk about his case for a little bit here. And so what you can see when he's trying to open his hands here while I'm holding his wrist fixed into a more extended position is that he has a really hard time opening his hands. And if you watch me, I'm watching both his fingers and his face, because kids have this remarkable reflex that when they're trying really hard to open their fingers, not only do they do it on both sides, they open their mouths too. And so I can see that he's giving me a really good effort when he's trying to open here, but it's just really hard for him. And then on the flip side, when I let go of his wrist, when it cycles back through and his wrist is down in flexion, you'll see he has better range of finger motion in that position. He can open those fingers a lot wider when his wrist is down than when I'm holding him up. So he would not be a great candidate for a traditional carpal wedge procedure, because if we bring that wrist up and he can't open his fingers and we get his hand stuck in a fist, that would be terrible, right? much better where he is right now than with his hand stuck in his fist and he can't use it anymore. And so this was a reason for a lot of patients that they're not candidates for carpal wedge, although there's others as well. And I, wanted to talk for a moment about what it's like, trying a new procedure, and it's a big risk for everyone. It's difficult, it's challenging for me, us as surgeons, it's challenging for the patient and the families to, have the trust to take that risk for you, and it requires a lot of discussion up front about pros and cons, possible outcomes, benefits, risks, what we can do about it if those things go wrong. And I figured that there was no one better to kind of share some of those things with you than Joe's mom. So I'll show a quick video of her talking about some of the things that we talked about before this.
Tractions are really tight facing in. You couldn't reach and grab things as easily, and we kind of knew that had to change. But the concern was that if we pulled his wrist back with the carpal wedge, that his fingers would pull even tighter into his palm, and then I was afraid that instead of fixing things, we would lose function.
So we talked, in depth about a lot of these potential risks and the potential benefit of doing it. And when you find that right person, that partner that's willing to take the plunge with you, so to speak, that's when we can make that innovation surgery. And it's it's a risk, but with risk comes reward. And so this is an example of what that carpal wedge looks like. I won't go through it again because Dr. Engles already talked about it. And then the flexor pronator slide is a big procedure. It's detaching all of those muscles from the forearm and sliding them down. But fortunately, we got the reward side of risk, and here you can see Joe's function on his right hand afterwards. Now his wrist is still flexed, but it's a lot straighter than it was before, and he can open his fingers and use his fingers, most importantly. And you can see that he's actually manipulating those coins quite well with that hand. And then in contrast, when you look at his left hand, which has not had surgery, that it's much more difficult for him to use his hand on that side. You'll notice he's picking up the coins with his right hand and passing them to the left, so there's better dexterity on the right side than the left side. And so you may wonder why not do the other side. It's certainly a consideration, but I think there's a lot of things to try and figure out, and there's sometimes when you need wrist flexion. And some things to think about are if you don't have great elbow bending, you might need your wrist flexion in order to reach your mouth. If you don't have great shoulder motion, you might need to wipe between your legs in the bathroom instead of going around the back, and that requires more wrist flexion in order to get into that position. And so I think that it's a very careful balance in these patients trying to get the right position to optimize them for all the functions that they need to do in life. And I would rather wait until a child is old enough and we make sure that they can do eating and wiping and everything else that they need to do with their wrist and extension before I would sacrifice that wrist flexion, because I would hate to take away some independence or self-care from any of my patients. And so then I have a little clip of Joe's mom talking about what things have been like after surgery.
Flexor pronator. And the possibility of kind of correcting those things. And so we went into it, and you never know what's going to come out, but it was really positive, I think, for him. We didn't really know with with writing and things like that yet, and to some extent we still don't, but definitely he's able, there's things that he's able to do that he wasn't able to do before, or more easily. That, and I see it even more watching this now, because you have the comparison of these two hands, what they can do. So he definitely, we could walk, I can hold his hand when I usually, this hand I hold his wrist, and this hand I hold his hand. And the difference in the way he grabs things, with the right hand like this, and the left hand like this, the finger movement. And I really like that he takes the hand naturally in his fingers. In fact, I think even if we don't do the wrist on that one, I'm tempted to do, just the fingers.
Well, that's a good day in the office, right? When someone comes in and they say, "This is so great, I want to do the other side," like that makes it, right? And so that's always the goal. But it's such you know, it's the biggest privilege, I think, of this job is to be a part of your child or your family or your story and being there for the highs like this and also being there for the lows. Hopefully there's more highs than lows, right? But I think it's just such an honor to be a part of that story, to watch your children grow up with you and be hear about the struggles and the challenges that come up and how they overcome each and every one of them, come out stronger on the other side, and you know, achieve every goal that they have for themselves and surpass maybe even their own expectations. And being able to do that as a part of a team together with Dr. Engles and Jerry and our hand therapists and you and your children and all of us working together hand in hand to get their best possible outcome. You know, that's what makes it worth it at the end of the day. And so with that, I will leave you with one last video clip for the talk.
But when I first noticed that like his hand was open and I could kind of hold his hand, it was really sweet. He's my little one, he's my baby. He could hold hands with mama. It's really nice.
Thank you for your attention. And I think Dr. Engles could come back up and would be happy to take any questions. Yes.
Okay, so if you do the circle with surgery where you're going to straighten out the getting rid of some of have there been studies done to see how much that will enhance the grafting ability, the regular motion, or the strength of the fingers, and
Yeah. Dr. Van Heest's study looks at that, and they looked at some of the I think it's parental questionnaires about function and so forth. And then there's another study out of South America, which is I have it highlighted where I have the diagrams of that, and they talk a little bit about what the average range of motion improvement was for their patients. So if you Google dorsal carpal wedge osteotomy, there's several papers that you can look at, you know, the scientific data. Oh, I think anytime you can take the wrist from being in a flexed posture to a neutral or extended posture, you will have improvement in grip strength as long as the fingers are working to start with. As long as there's not another neuromuscular condition that keeps them from flexing their fingers. But if they have flexion down here, if you can get them to neutral or better, they're going to have a better grasp. You know, I can't give you a specific number, like in newtons of force or something like that, but I think that what we see in the office is kids having better dexterity and better grip function. Yes?
Unrelated to your surgery, I think it's common to see patients with hip aplasia that have a chronic motor dislocation. Is that a common thing or never seen? Or?
I would say we more frequently see a radial head dislocation. Yeah. I've seen it several times, yeah. Yes.
Casting on the wrist to try to gain extension.
Sure, yeah. Oh, you bet. And we do that more than we do surgery. And what we'll typically do is we'll start with splits. And splits and not making significant improvement over time with splits. We'll try serial casting. And our therapists have really good results with serial casting. Now, it's kind of a little bit of a pain because you got to come back every 3 to 5 days to get your cast changed, but it can make a real significant difference. And then once you obtain that with the serial cast, a lot of times we can maintain it then with splits or nighttime splits and so forth. Yeah, the vast majority of our patients, you know, are treated just with therapy or have an extensive run of therapy before we end up operating. Now, there's a couple exceptions. For instance, the elbow release. Um, the, the literature would suggest that you'll get a better result if you do it before 2 years of age, as far as getting that maximal flexion. The results tend to drop off after age 2.
With the elbow, sometimes it can be so rotated and so stiff that it's even hard to tell which direction flexion is. So I've seen some kids that have developed instability of the elbow from stretching the elbow in the wrong direction because it's so far rotated. So sometimes if there's not a little jog of motion there to start with, trying to stretch it too much could occasionally be detrimental. I think you had a question.
My son's 4.5, and we're very much in the waiting period. He has full death, and we're very fortunate. And so we're considering maybe in the future we talk about what might happen. One would be CRP or a distance transfer for increased flexion in arm. You mentioned the age of 7, I think, was after the age of 7.
Yes, so I believe in Dr. Van Hees' study, I think the age was 7, where they found better results in the kids who were a little bit older, that were older, over 7, and if they transferred the ECU simultaneously instead of just doing the wedge.
Okay, I guess my specific question is, if we have a luxury to get an age, do you have a recommended age that is ideal for outcome? Or let's say a lat transfer for flexion right there. Is there a recommended kind of age range that's ideal, or is aftercare as well as therapies and
Yeah, exactly. It somewhat depends on the child. The biggest thing is them being able to participate in therapy afterwards. It is a fairly intensive rehab for the lat transfer to learn how to fire that muscle as an elbow flexor. Although kids honestly pick it up pretty quickly, but it still takes a fair amount of training with therapy and whatnot. So they need to be old enough to have a reliable exam in the office, so we can test that latissimus muscle and try to make sure it's there and functioning, because not everyone who has arthrogryposis has latissimus that's working at all or well enough to transfer. And then they need to be old enough to comply with therapy. So I would say like an average is probably around that 7 roughly year age also, but it's not a hard and fast number. It depends on, some kids will be ready sooner, some will be not ready yet.